Thank you. So as mentioned before, we are lucky enough in the United States to have a lot of real food formulas and plant-based formulas already. So I am going to talk a little bit about my experience using real food formulas as well as plant-based formulas. But in addition to being lucky to have the formulas, I'm also lucky to work on a team that is very innovative and willing to try new things kind of at the cusp of them coming out. So this was already mentioned a little bit before, but we're seeing the rationale for our patients asking for real food formulas or plant-based formulas, whether it be allergies, whether it be ethical reasons or religious reasons, maybe to improve GI symptoms, or to decrease the reliance on the healthcare system so they're not needing prescriptions for enteral formulas and things like that. We did learn that we had some work to do and some benefit that we could provide. So this initial study was survey of almost 2,500 dietitians and really asked, do you recommend real food or blenderized formulas? Do you use these in your practice? And about half of them said yes. But many of them said that they didn't feel like they had the education or the knowledge or expertise to recommend this. And so most often they were doing it because of the patient requested the formula. So then we asked parents, how many of you are using some type of real food formula at home? And again, half of them said yes, at least some of the time that I do use these formulas. But I'm only referring to a dietitian about half the time. And that was a pretty big concern to me. I have listed here some recent evidence that has been published in the last couple of years, just to kind of get you thinking and looking where we have seen decreased utilization of healthcare and improved GI tolerance. But I do want to highlight a couple of these. So the first one is a paper on 30 patients with head and neck cancer who had gastrostomy tube feeding, and they were on a standard commercial enteral formula. They were changed to a real food-based formula, a combination of some options that had meat in them and some options that were plant-based. Again, we have a lot of options in the United States. And really what was found is that using the real food formulas was very effective in stopping their weight loss, improving their GI symptoms, increasing quality of life, and increasing their total calorie intake. And interestingly, during the study, the physicians that worked with these patients saw their patients doing so much better. They actually wanted to stop the study early and just put everybody on real food formula, but we told them they had to wait. Another study from our institution, probably in about 2010 or so, I started to become interested in providing real food to patients with enteral nutrition. And so we started, and at that time there really wasn't a lot of evidence or even about safety of doing this. And so we decided to give about 20 of our patients a blender and a recipe, and for 6 weeks we had them go home and make their own formula. And we found out that it was safe, no one got foodborne illness, no one clogged their enteral access device, and we were able to have them maintain their weight or gain weight if that was the goal. More recently, we looked at our database of patients and really wanted to get an idea of how often are we changing enteral formulas and why are we doing that? So we looked at our patients, about 1,600 patients from 2018 to 2020, and 20% of them reported enteral feeding intolerance. Now I know that is subjective, however, they were reporting things like vomiting, bloating, diarrhea, and reflux, leading to not getting their goal feedings. So often this led to us trying multiple different formulas, and many times a plant-based formula or a real food-based formula. In the US, in the plant-based space, we do have standard polymeric formulas and peptide-based formulas, so those were some of the options that we used. But really over the last 3 years since we've looked at these patients again, we've just seen a dramatic increase in using the plant-based formulas. And I used to offer it when someone asked me, oh, I heard there's plant-based formulas, can I give that a try? But I've seen such a benefit with the improved tolerance that I like to present it more often as the first line. So in addition to Aspen also is coming out with clinical practice recommendations for the use of both home blended formulas as well as commercial blended formulas. So that will be in your hands very soon. In the next 2 months, I would say you'll see it in print. But I did want to highlight a few of the things that are normally hesitations that people say, oh, I'm not really interested in trying that because I'm worried about maybe the enteral access device would clog more often or need to be changed more often. And when we were doing the research for this project, we found no evidence that the tubes clog more often or needed to be replaced more often, as long as the home blends were blended at an appropriate time, and the recommendation is 3 to 6 minutes, and that we recommend using the International Dysphagia Diet Scale to measure the consistency of the blend once it's made. The second hesitation I think that people have is microbial contamination, and there really is no evidence of clinical correlation with an acute infection in patients and the microbial load of enteral formula, as long as patients are following appropriate hang times, which we'll talk about here in a minute, as well as food safety practices and cleaning practices, especially of the blender. I think these hesitations can be mitigated. And then lastly, follow up with a dietitian is important to have a successful regimen as we start to use different avenues for getting nutrition needs met. So you might be asking yourself, well, out of all of these options, how do I choose what I would give to my patient? And that would be how I felt as well. So I normally start the conversation with saying, what did you normally eat before, or what does your family eat? And try to navigate the options that way. However, Aspen does have a clinical formula guide, which actually lists the milk-based and soy-based formulas in the same categories as the plant-based formulas. So polymeric, peptide-based, real food-based. And so that can kind of help give a direction as well. And I realize when a patient is in the ICU or in the hospital, they might not be part of this decision at first, but becoming part of the decision as soon as possible, I think really helps build the rapport with your patient. So this is a journey, like I said, never ending. There's lots of options. Some of the options I have listed here are using just a standard commercial formula and blending in a food. For example, we might blend in green beans to help with diarrhea. Using a food-based formula, but mixing in different fruits or vegetables to increase food variety. Using a food-based or plant-based formula on its own, or doing your own blending at home using a standard recipe, a recipe builder, or exchanges. Now, I think that the ideal situation might be that we use formulas that have real food and that are plant-based. So there was a nice abstract at Aspen this year in Las Vegas, retrospective look at 448 patients that were fed a commercial blenderized formula, and that was a combination of meat-based and plant-based, compared to just a liquid plant-based formula. And what they found for these patients that were on formulas for 7 days after hospital dismissal, that there were less complaints of GI intolerance for the patients that had the blended formulas, both the plant-based and the meat-based, versus just the standard plant-based formula. So something to look at in the future. Using a plant-based formula, standard formula, is a way to create your own blended formula though. So you can see this picture here. I have a patient who is very artistic, and she likes to create different colors in her foods. So using that plant-based formula to start with, but might add in banana, oatmeal, blackberries. You can see here there's one where she has a bunch of strawberries and raspberries to help kind of make more of a meal that would be a combination of the two. Some other options would be using a pouch product, which we do have in the United States, and adding, fresh picked blackberries. You went raspberry picking or blackberry picking with your family, and you might feel like, oh, I would really like to enjoy that food that everybody else is enjoying, and mixing that into a product that you have at home. Adding coconut oil or peanut butter, things like that to add calories are also good options. Again, you can see here the beautiful colors that she makes. This was for Christmas, red and green for Christmas colors. And I do want to just mention the recipes that I alluded to earlier. So having a standard recipe is an option, and there are some nice standard recipes that will be in the ESPEN clinical recommendations. But Complete also has a website in the US where you can create your own recipes at home. So you start with a nutrient-rich base, such as a commercial formula or a plant-based milk, and then you start to add fruits, vegetables, whole grains, proteins, and the builder helps you create a nutritionally appropriate formula for what your goals that you have set. It also creates a shopping list, so it is a nice way, especially for dietitians who might not be comfortable in this space. It's a good way to get started. Like I mentioned, I like to remind everyone of the hang time of these products anytime I talk about blending in foods. So food of any kind, the hang time is 2 hours, and it's 1 hour if it's an ambient temperature of 90 degrees Fahrenheit. Commercially prepared formulas that have real food have anywhere from a hang time of 8 hours to 12 hours based on manufacturer recommendations. And adding modulars to these does decrease the hang time by 4 hours. One thing I always like to mention, I know that people do try to add ice packs, but we have no evidence that shows adding ice packs would increase the hang time of any of these formulas. So I'm gonna shift a little bit here and talk a little bit more about plant-based diet. So as you can see here, all of these organizations recommend a plant-based diet for a variety of reasons that we have listed here. And in my opinion, if these are recommended for healthy people, why wouldn't we be recommending these types of diets for people who have enteral nutrition? So that might be cancer prevention, decreased risk of heart disease, weight management, longevity, sustainability reasons. For example, the European Society of Cardiology says plant-based diets are better for your health as well as for the climate. And another thing that I found interesting is European Parliament has recently adopted a resolution that calls for member states to help consumers eat a more healthy plant-based diet and decrease reliance on animal products. So again, these are recommendations for healthy people, and I feel like for our patients, it's important to look at as well. So I think the number one question people ask is, well, how will I build muscle, or how will I get enough protein? And plant-based diets absolutely can provide adequate protein. So having essential amino acids to support growth and amino acids that are digestible and absorbable is achievable with a plant-based diet. Right now we have two ways to score the absorbability and digestibility of protein, as you know. So for the first one, the PD-CAS, this might be a little bit more older recommendation because it only takes into account the amino acid quality based on total fecal digestibility. So this might cause an overestimate of protein availability because proteins are synthesized by microbes, and other non-dairy proteins also end up in the fecal content before being measured. The DIAS might be a more updated version of how to measure the digestibility of protein, as that really measures the amino acid quality of food based on ileal digestibility. But really, I would argue that these scores are less important as we get a wide variety of plant-based foods in our diet. This is just to kind of give you an idea of the DIAS score and the PDCAS score of milk and soy and other plant-based products. So you can see that definitely plant-based foods sometimes have a lower of digestibility and availability, but these can be mitigated. Again, an example of essential amino acids that are in different foods. So you can see absolutely there's much more leucine in whey than other plant-based proteins. However, in general, you can see that these plant-based proteins actually have higher amounts of arginine that we know is good for our immune system, or glycine. Another thing to keep in mind with plant-based protein is plant-based sources of protein are lower in calories than animal sources, for example. So you might end up needing more of that product to meet energy needs anyway, which would in turn help increase the protein intake. And protein blends and using combinations of ingredients can definitely have a PDCAS of 1 or a DIAS of greater than 1, which would be the same as whey protein. And we probably all learned this in our studies, that you can eat rice and peas together, you can eat peanut butter and whole grain bread, or oats and nuts together, and these help create that complete protein. But there are other ways to do that as well when we're thinking about an oral nutrition supplement or an enteral formula. So plant-based isolates and concentrates are widely used, and these have high digestibility scores. In the US, it is common to enrich formulas with individual amino acids to really make these oral nutrition supplements and enteral formulas have those high scores of digestibility and absorbability of protein. So I want to end with a couple case reports just to kind of give you some idea of how we're using this as a team in practice. So this report is a 66-year-old male who had a stroke and continued to have dysphagia, so was dismissing home from our inpatient rehabilitation unit with enteral nutrition. Initially, like most of these patients, he had an NG feeding tube, and the dietitian started with a 1.2 cal per mil standard formula. He later had a peg placed and was changed to a 1.5 cal per mil formula to decrease volume. But when he was ready to go home and all of his supplies were set up, his wife got to looking at the carton of enteral formula that they were going to go home with in her mind for the rest of her husband's life. And she got very upset. Why wasn't I involved in this conversation? We don't eat the foods that are in this product. I want to know what other products were out there. And in the end, they chose to pay out of pocket for a plant-based product because that was what was important to their families. So a learning experience for me was not to assume that they didn't want to pay for something, and they felt like they were withheld information. Secondly, this is a 70-year-old male who was on a standard commercial formula, similar in the study that I mentioned earlier, getting chemo and radiation for tonsil cancer, and reported his whole life he could never have milk products, but he called it lactose intolerance. So we thought, well, you can have a standard commercial formula. But throughout the time of being on enteral feeding, he complained of fullness and bloating and really just unable to get his goal feedings, leading to a 5% weight loss in 3 weeks. So we decided to change him to a commercial blended plant-based formula, and he had improved tolerance, was able to get in his goal feedings, and his weight did stabilize. One thing I will mention is we did have to increase his calorie intake by about 15% when we did that, and my theory is that the thermal effect of food may require more calorie expenditure as we use more whole foods in our formulas versus substrates and concentrates. So that's something to definitely keep in mind. And I know other groups have published papers in pediatric patients where they've had to almost double the calorie requirement because of the difference in the digestibility and that thermal effect of food. Lastly, this is a 26-year-old who was in a car accident and had a closed head injury that resulted in dysphagia and had a feeding tube placed. So he was going home with this peg, and when he was first in the ICU and in that acute phase, he was started on a standard high protein formula. But as soon as possible, the family requested blenderized diet right away and said that he had followed a plant-based diet at home. And so when the patient was in rehab, we allowed them to order from our pureed menu in the hospital, and family actually administered that pureed food through the tube. Now quickly they learned as they were getting ready to go home with many therapies, physical therapy, occupational therapy, maintaining this at home was going to be difficult. So they decided to dismiss on a combination of a little bit of home blending, but then a commercial plant-based product. And 2 months later, when I saw him, he still had some communication difficulties, but he was advancing with his therapies, he was improving his strength and working with speech in hopes that he was going to be able to swallow and eat again. But he wrote a note for me that said, "Thank you for helping me maintain one aspect of my life that didn't have to change after the accident. I feel so good that I can continue my plant-based diet via tube until I can eat again." I will end with this slide. Many people ask, can you build muscle with plant-based protein? And absolutely you can. This is 315 pounds of pure muscle and strength who follows a vegan diet. And as many of you may know, that is also common in the NFL and amongst other athletes. So I will end with our conclusions and we will go to question and answer.